Payment methods are often blunt, they are often difficult to understand, difficult to administer, and they sometimes have unintended consequences. But when we think about the range of our alternatives for improving the structure of the delivery system and promoting the coordination of care for the benefit of the patients, what are the alternatives to payment methods? The first one that will come to our mind is medical education. That's a wonderful thing, but that is what we call the slow boat to China. If you want to change physician behavior by changing the way doctors are trained, that's a long-term process. Second option is continuing education and professional sanctions for misbehavior. Well, that's important as well in the professional societies, but we find that those systems tend to be captured very quickly by the professional societies themselves, and they are not necessarily all that effective. A third mechanism is more medical malpractice litigation, sanctions of that type. Those have a role to play, but they are expensive and they can be nasty as ways of getting things done. And the final is command and control, or we call it slow torture and torment. Compared to the alternatives, payment incentives actually can be quite pleasant and quite cost-effective. We recognize that payment incentives are a major influence on behavior, and that most payment incentives pay in fragmented ways. That in turn leads the physicians and the hospitals and the other providers to be uncoordinated in their activities. This is, to some extent, the menu. Global capitation is the way we use that term. If for all services, this would be for the system, the payer, to pay provider organization for GP services, specialist physician services, pharmaceuticals, hospital care, home care, etc. And that gives you all the responsibility, but all the risk to manage all that. One step down, very common in our context in the U.S., is what we call professional services capitation. This is payment for all physician services, but not for the hospital and the pharmacy services. So now the provider organization, the medical group, has to cover all of its own salaries, but it isn't actually it doesn't pay claims to hospitals, for example. A third is condition-specific capitation. Here the concept is to give the providers a sum of money for all the care required by people, say, with diabetes over the course of, say, a year. And coordinate all the different components of that under one budget. A dilemma, of course, will always be, well, some patients have multiple comorbidities. How do you manage? Fourthly, acute episode payment. This is closest to your PBR, in that typical example would be knee replacement surgery. So the idea is to single payment, all of that to give the incentive for that team to really think of itself as a team, that they have $1, as we put it, and so that they all have the incentive for the very first time to worry about the efficiency of the whole process. All of these methods are designed to give the receiver of that an incentive to care about the behavior of others. But if you're just wasting money, and I'm a doctor, I don't want to get involved in that. I don't want to argue with you about that, And you don't want to argue with me either. But if we're paid separately, we don't have to. But if we're paid together, then it's like we're in this together. You don't want to give comprehensive global capitation to a group of GPs. Once they've referred the patient to the oncologist or the orthopedic surgeon, they have very little influence on what happens after that. And to put them financially at risk is just setting them up for failure. And so you have to monitor that. But an entity that has the specialist inside, maybe center includes a hospital, includes the specialist, is more able to conduct that. Many of us favor as an endpoint some variant of global capitation. The idea that you really want to have the providers working together across all conditions and across both the chronic and the acute manifestations of those conditions. However, we know that creates lots of demands on the system, and so some of these subcomponents can be, even within large systems, can be very useful. Population-based payment has virtues, but it needs to be supported and supplemented by at least three entities. I'll go through very briefly. First of all, organizations that can have the capabilities to actually accept and manage this. This is really a long-term process. This involves financial accounting methods, financial reserves, a culture of cooperation. Secondly, there needs to be incentives for the consumers, for the patients. Because one of the things, the failures that we did in the United States was to try to do revolution in healthcare without bringing the patients along. And the patients experience change as frightening. And so you need to have some ways of both positive incentives for rewarding behavior by patients in taking care of themselves, cooperating, adherence to their physicians, and negative incentives to discourage them from using unnecessary and inappropriate and low-value services. Although we all believe a lot of this is about promoting and improving primary care and chronic disease management, still where most of the money is in healthcare is not at that level. Most of the money in healthcare is in the hospital, and it's in the specialty providers, and it's in the new drugs, devices, diagnostics, imaging, and all of that. And you need to sort of simultaneously be improving the efficiency of the specialty services even as you're trying to build, if you will, the capacities at the GP and the community basis. These three challenges are the challenges that we face in the United States: organizational development at the provider level, the appropriate incentives and engagement for the patients and the consumers, and how to deal with new technology. And I would submit that those are three of the major challenges and opportunities facing you as you think about payment reform. Payment reform is a big part of where you're going, and these are all parts of that. And thank you very much for your time.